Hi, everybody. I will start. My name is Erin Ziegler. I am an assistant professor at Ryerson University, and I'm a practicing nurse practitioner. And I am here with Ben, and I will let Ben introduce himself.
Hi, my name is Benjamin Carroll, and I'm with Erin, one of the co-creators of the Soji website. I'm a PhD student at Queen's University and a public health nurse at Ottawa Public Health. This project that we're presenting here today was funded as a trainee grant in knowledge translation, and it was directed at the knowledge to practice gap in healthcare for lesbian, gay, bisexual, transgender, queer, intersex, and two-spirit people. So welcome. Thanks for joining us.
So today we are going to talk to you a little bit about the knowledge translation project from a design thinking perspective, which was the aim of the training grant. We're going to talk a little bit about our ethical barriers and facilitators when we developed a community-based collaborative simulation game. And we're also going to look at the concepts of cultural, humble, and safe healthcare for those who identify as a sexual or gender minority client. And at the end, we are going to have a demonstration of one of our games and open up for any questions.
Okay, so the trainee grant from the CHR included participation in a 2-day knowledge translation education development initiative based on the theme of innovative thinking to support LGBTQI2S health and wellness. And so this event included local healthcare practitioners, LGBTQ community members, graphic designers, marketing experts. And so they all helped the trainee team develop campaigns, services, or products, whatever the team decided, to disseminate research evidence to improve health outcomes. And we've linked to a couple of the other completed projects on our website also. There were probably, I think, about 36 other people there in total. So with our team of 3, it was 39. Oh, we had another teammate, Chris Shortle from Memorial University, also participating with us. And so the Design Jam event kickstarted the whole use of using integrated knowledge translation methodology, which incorporates expertise from the two-spirit, lesbian, gay, trans, queer, intersex, and asexual and other community members throughout the knowledge to action cycle, shown on the left there. And in our case, we integrated community members not only at that Design Jam event, but also in script writing, the acting portions for all people with lived experience, in the virtual game development, and the knowledge tool development process. So, and there's one of the publications that we've created out of that since. But there were a lot of ethical facilitators and barriers. So we had story developers, script writers, and actors from the sexual orientation and gender identity minority communities throughout. And so a person with lived experience will be able to portray the role in a more convincing manner than a professional actor or standardized patient following a script. And this authenticity respects the dignity of trans and sexual orientation minority folks to not be portrayed by others in an unsympathetic, stereotyped, or erroneously dramatized way, whether or not that was intentional. So for example, the use of the word queer with an older gay man, Wolfgang, in one of the games. Some actors may portray his dislike of this word as like being really indignant. But our community participant, who himself is a gay man who dislikes the word queer, he kind of acted it with this resigned and quiet like weariness, like just from years of just sort of dealing with this, right? And so I thought that was really an interesting thing to notice in his acting. Um, and aligning with the standards and best practices, standards of best practice simulation, we included planning for the preparation, participation, and debriefing phases of the process with both actors, and recommendations for site users to promote psychological safety for the participants. So you can keep that in mind when we demonstrate one of those at the end, demonstrate one of the virtual sim games. And finally, the use of video simulation also preserves the right of the health practitioner as a student to take risks in the simulation environment and not risk traumatizing trans folks for whom the scenarios portray negative clinical experiences. And for folks who do live actor sims, like having to do 4 hours worth of really stressful situations is a lot more onerous than kind of doing one video with some of these negative portrayals. Some of the barriers, we had no control over the participants at the Design Jam event, and so important people in the community were missing at that inception of the project. So for example, new Canadian refugee, Black and Indigenous people and people of color, both queer and trans, and people over the age of 50 were not included as community participants, whether that was a recruitment concern or just the area of Vancouver that they were recruiting from, I don't know. And research with any vulnerable population requires a thoughtful approach, and we've been learning from our errors. We'll describe this in an upcoming article about working with trans and queer actors. However, the continual colonial trauma of First Nations, Inuit, and Métis people in Canada requires that our approach to addressing healthcare education for primary providers doesn't merely incorporate Indigenous experiences, but is led by Indigenous people. For example, the concept of two-spirit and its relationship to identity, community, spirituality, activism, and Indigenous diversity in a colonial context is too complex and multifaceted to be captured in a virtual game without risking doing more harm than good, so reinforcing the stereotypes. So connecting and building a culturally safe educational resource for health providers using Indigenous methodologies led by Two-Spirit, queer and trans, First Nations, Inuit, and Métis people is a priority for applying for further grants to continue to develop the site.
So we came up with the name sexual orientation and gender identity. So we abbreviated it to SOGI. And naming things is always one of the hardest things for me. We wanted to come up with something that was going to be easy to remember, but also clearly sort of identified the aim. And so the project really wanted to look at sexual and gender minorities. And initially, the funding was from nursing. We looked at it from a nursing perspective. So we did add the word nursing in there. However, through development as well as some implementation and evaluation, we've really realized that it's very useful simulation for all healthcare professionals, really to be able to use it as a tool to help them learn more, to address their learning needs, to provide a cultural, humble approach to the unique healthcare needs of individuals who identify as a gender or sexual minority. So what we did was we developed a free open access e-learning module, which although, like I said, initially was for nursing, it is open to anybody. And we originally created 4 video simulation games, which we'll talk about later. We also have a series of videos in terms of background videos about cultural humility and doing assessments. We have self-reflection activities, and then we've developed a list of curated resources. So resources in general, but also resources for each specific game. And the way that we did set up this was originally looking at the competence that nurses in Ontario need to have when we renew our license in terms of developing a learning plan. So our learning plan has to have a goal, objectives, activities, and then evidence. And so we really set this toolkit up as sort of a nice package that a nurse could use this as their learning need, their identified learning need for their college renewal, but then be able to also use these tools in courses or classes as a whole e-learning module or as a standalone simulation game.
And one of the great bonuses with working with CanSim is they've provided open access for us for all of these on their website, and we're very grateful for that.
So the introduction to the site when you log on does have some foundational videos. And these are videos that we put together as a recorded PowerPoint, which can be obviously looked at again in a group setting or as an individual preparation for class. The main ones that we have developed so far is talking about cultural humility as a concept, some general terminology, basics of terminology for sexual orientation and gender identity, and then key points about doing health assessments. So taking a history and doing a physical assessment on an individual who identifies as LGBTQ2S plus are identified here. And again, these videos can be looked at individually or as a group.
So just a brief little orientation to cultural humility, because it's often lumped in with cultural competence or cultural safety, and really it's distinct from those two things. It's something that the healthcare practitioner provides in the care interaction to create cultural safety with the participant or the patient, the client. And healthcare providers are culturally humble by being open to new ideas, self-aware of their personal strengths, limitations, and values, aware of actively changing power dynamics, providing meaningful interactions, navigating patients and groups through systems that may present unique barriers to them, as well as being critically self-reflective on their own biases and assumptions. And it also includes self-awareness and knowing that awareness of biases isn't enough, that there's the element of lifelong learning that's reflected in Ferranda's model on the top, and that you must actively work against those long-standing beliefs. So the model on the top is Ferranda and others, and it's based on the theoretical framework by Tervalon and Murray Garcia in 1998. That's the seminal document. And what it doesn't include is systems critique. So that's critical critical reflection on systems and their barriers and the power dynamics in them. And it's an essential element of cultural humility as well. And so a number of these factors are similar to or the same as themes of fostering a therapeutic relation described by nurse practitioners in the model shown on the bottom. Canadian nurse practitioners when they were looking at what their defining characteristics were as well. So it really taps into nursing at various levels and really all healthcare interactions. And so we used it as the theoretical foundation and central relational concept underlying the entire SOGI nursing project. And so this is sort of looking at the relationship of cultural humility with cultural competence in a little bit of a hierarchical way. That dark line across the middle sort of depicts that transition from everything that the healthcare provider brings, and that line is that interaction between the patient or client. And on the right are the goals related to the knowledge of our patients, families, groups, communities, and populations to each cultural care model. Cultural safety as an outcome means that health practitioners and policymakers can't declare something culturally safe. Only the individuals, families, groups, communities, and populations we're working with can tell us if our care is safe. I have a little bit more there, but perhaps we'll, in the interest of time, we'll leave it to questions if anybody has more questions about this, and we'll move on to the next slide because I like it better.
Sorry, I'm having a technical difficulty.
No problem.
Sorry, Mike, I've probably now advanced 10 slides, so
Oh no.
give me 1 second.
So there's Laura Kiln has a question. How
Oh,
would
I'm
you
sorry.
recommend? That's okay. How would you recommend assigning grades for participating?
Oh, that's a very good question, Laura.
You mind if I
Uh, yeah, sure.
So we actually, oh, sorry, it's trying to save something here. At Ryerson, we actually implemented this into the fourth year nursing clinical curriculum because we basically, as you know, placements are an issue right now. And so we wanted to be able to have some simulation options for professional development, but also provide them with some simulation. Okay, I don't know what my computer just did. Just give me one. I'm sorry. Anyway, and so what we actually did was we guesstimated that it took about 3 hours to complete the module in full. And so we basically provided students with clinical hours for that course. So if they completed the entire module and got the learning certificate at the end, we gave them 3 hours of virtual simulation clinical hours. And so that was one option that we did at Ryerson. The other thing that the simulation hours have also contributed to 1 hour of simulation was 1 mark out of the 50% that they needed. Okay, now we're zooming 10 times because my computer is going crazy. So we sort of did it that, if they did the simulation, they got, it ended up being about 3% of their mark, if that answers that question.
Thank you. It's helpful to know how you've used it. I'm going to listen some more. I don't teach a clinical related course, but I was thinking about integrating it potentially to replace theory, like a theory class, in which case it would be nice if there was some sort of incentive attached, perhaps in the form of grades.
100%, Laura. We know that incentives for grades get things done. And so, like we said, everyone is different. So right now to do the 4 games and all of the videos, it's about 3 hours. We'll talk about it a little later that we encourage people to actually pick the wrong answers so that they can see some of the wrong answers. But if you kind of, we find at Ryerson that even a small percentage people will do it. So even if it is something as small as, 3 to 5%, they'll do it.
Thank you.
Can I also ask a question?
Mhm.
Hi, Erin. Can you hear me?
I can hear you.
So I'm just wondering in terms of, so this was integrated into year 4 at Ryerson, but I know a lot of times we're thinking about starting this type of like using proper language starting writing year 1. Is that something that is like, or is there scaffolding like in terms of how much people can be learning? Like they start with this in year 1 and then, we don't just assume that they know it. It's obviously a continuous learning and building that they're doing in their entire 4 years. But has that ever been a part of a discussion at all that you've had?
So obviously trying to figure out where it best fits in the curriculum is an ongoing discussion. I think because of it being a simulation game, it was adopted into the 4th year specifically at Ryerson because we needed simulation experience for clinical. And, this year has been a little bit different all over. So I think there is the opportunity, especially for some of the framework stuff, the talking about cultural humility and talking about LGBTQ terminology and the normalizing of it definitely has a place in 1st year.
I also think too that it lends itself to reflection itself. So how you used it, not only in the immediate sense, but it'd be interesting to come back with a class of students that you ran through some of the simulations in their 1st or 2nd year and ask them in their 3rd and 4th year after they've been out in the world a little bit more in their nursing role to see like what what are your thoughts on this now? How did you play the game differently? And what did you notice in the game differently that you didn't notice when you were in first and second year? I think the theory stuff would also come back to them in a different way, and they'd relate to that in a different way. And it would make for a nice kind of reflection on that as well, I think. Which also segues back into this great slide that I love. This is the continuum of cultural safety model from the Public Health Agency of Canada's 2019 stigma report. They've recently released a second update to that based on COVID and vulnerable populations as a follow-up related to COVID. So I think that's an interesting pairing as well. So this emphasizes the role of the patient, which is represented by the yellow circle in defining a culturally safe space. Those are the things that the client needs from us. The bracketed approaches on the left are including cultural humility at the bottom, are what the practitioner needs to bring to the interaction in order to create a culturally caring interaction. And so the 4 culture care concepts within that yellow circle flow in that hierarchy that my clumsy pyramid had in the previous slide. They represent what the patient group or community needs from the healthcare providers, with cultural awareness is the bare minimum. So that's maybe where that scaffolding comes in, Barbara. That cultural awareness and cultural sensitivity in the first and second years, what does that mean? And that would be building on what I would hope is still in social studies type curriculum from high school and junior high. And then co-created interactions of cultural competence as they're engaging with evidence-based nursing practice, and then cultural safety as they're engaging with patients and clients. So I think this model might help with some of those ideas, as well as what to integrate within that for terms of trauma-informed care and anti-racism type curricula. So we can move on to the next one there, Erin.
So now looking at one of our e-learning modules. So this is Connor. And so basically it is from the perspective of the healthcare provider. So we film these from a first person perspective. So you are seeing what the nurse is seeing in this case. So you are getting to see the nurse looking at the patient. So if you're doing an assessment, you see what the nurse sees. You get to see the reaction of the nurse. And so this is one of our examples, and we'll show you the video later, but this is how it looks. And then basically as it goes on, you get a decision point and you have to make a decision. So Connor is coming in because he has a cough. He is a trans man and he's wearing a chest binder. So basically the first question is, how are you going to be doing the physical exam? So when preparing to conduct a physical exam of the respiratory system, what are you asking the patient to do? And there's 3 options there. There's the allow the patient to leave their shirt and binder on, leave the binder on but put a gown, or remove the binder and put on a gown. And so basically you need to pick. It's choose your own choice. So you're going to make a choice and it's going to give you the rationale. It's going to play it out. So you're going to see the response of the patient when the nurse asks the patient to do something. And then it's going to give you your rationale that this is either the best choice or it's not the best choice, and provide you with the reason why. So in example for this case, the correct answer is that you need to perform an assessment without the binder on, because you need to be able to auscultate over bare skin. And so any barrier such as a chest binder could really impair your ability to articulate, auscultate properly for breath sounds. So as I mentioned, I like using this as a learning tool to not just, you don't want to necessarily just get 100%, because you actually will learn as well from the not best answers or the incorrect answers, because it will give you the reason why. So why is it not a best answer is that you can't hear properly. You can't hear breath sounds. It increases the risk of distorted sound. So we do provide you with that rationale. And I apologize again, my computer has a mind of its own today. So when you do complete it, you do get that you've completed the game. And we are providing you with a certificate of completion. And so this this is not a certification. You're not an expert. This is something that is really something to think about, that it's just that you've done the learning. So it's not that you should never do learning again. It's not that you shouldn't, check out our website again for when new videos come. It's just that you've completed this. So from an education perspective, the certification of completion, you would be able to get your students to provide you with a screenshot or a PDF of it that would show you that they have completed the current module that is on the screen, that is on the e-learning tool. And as I had mentioned previously, we also have a list of resources. So there's resources at the end of each game, and then there's also a general resource section. And we do have a tool that participants could recommend us with an additional resource. So we tried really hard to find all the resources possible, but that's never possible. So if there is someone that does come do a tool and realize that one of our resources is out of date or that there's something better, we welcome them to share it with us. And obviously we have that it also can be used in primary care in terms of not just education, but in team professional development or individual development to improve access to services.
Certainly, we know that like many queer, trans, two-spirit folks are invisible in our care, and they don't disclose their two-spirit, queer, trans status unless they think it's relevant. And there's a good body of research that shows that health providers assume that people are heterosexual or that their natal gender aligns with their gender identity. So unless they're told otherwise. So we hope that these virtual games and the associated resources will create an interprofessional conversation, understanding and collaboration in two-spirit, lesbian, gay, bisexual, trans, queer, and intersex care, and increased awareness and practice of cultural humility in the care of marginalized populations across practice. So beyond the queer, trans, and two-spirit populations, to look at and critique systemic biases and enhance the healthcare experiences of just folks in Canada in general.
Does anyone have a preference of which one they want to see? We have a transgender individual coming in for a chest assessment. It involves checking in. A link to any of the simulations they have handy. Marianne, they're just so easy to please here.
Oh, and I see Laura asks in here, I'd love a link to the simulation if you have it handy. So it's, if you go Sogi, S-O-G-I, nursing.ca, all one word for the Sogi, and it'll pop up. And I'll put it in the chat, and not just to Marianne.
Why don't you show Connor, Marianne, just because that was the one we were talking about?
Sure. So you can see the web page with the course, and it has the cultural humility video, the self-reflection, other resources, and then it has the 4 games. So we'll start with Connor's story. There's learning outcomes, there's a rubric, and then this would be the game link. And it is available in English, and the French is coming.
And that's important. We've tried to do as many bilingual as possible.
So just to clarify, the games are available in French and English. It's just the additional resources such as the rubrics are not.
Thanks, Jane.
Here's where the student enters their name so that they can have the name on the certificate. We always have the learning outcomes. A little bit of a case summary that Erin has already told you about.
Hello, Kate. I'm Jen, the nurse practitioner.
My name is Connor. I've gone through this with the receptionist. Did she not tell you? Because my birth name was Kate, but I go by Connor.
So there
So
was a
what-
little bit of a preamble with this one as well. There's a smaller mini game that's useful for showing in class, for example, to set this up, that shows Connor coming into the clinic, going to the receptionist, handing over their healthcare card, and getting misnamed. And it's just the one brief interaction with what would you do. And so it's good as a demonstration to how to use it, and it already introduces the story a little bit.
So what action, so let's open it up to the group. So you are the nurse practitioner, and how are you going to best respond to the patient statement? Are you going to ask why the patient's seeking care today, request to calm down, or acknowledge the patient's distress? So Laura likes number 3. Oh, everyone likes number 3. So can you click acknowledge patient's distress?
So everybody's thinking that's the correct one?
That's what they want us to pick.
I'm sorry, yes, I see there's a note that we're gonna correct your chart.
Thank you.
So that is the correct choice. So this acknowledges that the patient has some distress and you're desiring an opportunity to develop that nurse-client relationship. So you're all excellent nurses. Congratulations. For a learning opportunity, again, you might have picked something different to see the other outcomes. So now what's the next step? You've diffused the situation. What's the next step? You're going to clarify the pronouns and transition status, ask why patient is seeking care, or use patient's legal name. And feel free to recommend that you want to see something that you might not think is right, or if you're not sure. Oh, Barb wants to use the patient's legal name. Okay.
Okay, so Kate, why are you here today?
Come on, you gotta be kidding me. It's Connor.
So not the best choice. So you've continued to not validate his preferred name and pronouns, which is disrespectful. And it does jeopardize your relationship. So what happens now is it actually, if you hit return to the options, takes you back to those exact same 3 ones. So now you pick something else. So clarify pronouns and transition status, or ask why the patient is seeking care today.
Want me to pick the right one or the wrong one?
Let's pick the right one.
Okay, Connor, my pronouns are she and her. What are yours?
He and him.
And do you identify as transgender, non-binary, or something else?
I'm a trans man.
Okay, so Connor, can you also tell me why you're here today?
So by acknowledging his preferred name, you've taken a step to establish a good therapeutic relationship, and you've also opened it up to then continue the assessment.
So I've had this cough for 3 weeks. It's not getting better.
Okay, I'm going to ask you some questions about your cough, and then I'm going to do a physical exam, and I'll need to listen to your chest.
I'm wearing a binder.
Okay, when you're wearing it, can you easily take a deep breath?
Usually, yeah, but I can't right now.
Have you had any recent weight gain, or is the binder too tight?
No.
So you're going to do a physical exam of the chest. What would you ask Connor to do? Allow him to leave his shirt and his binder on, leave the binder on, but tell him to put on a gown, or remove the binder and put on a gown? Raquel and Barb and Laura all want to go 3. Yeah, Laura, it is familiar. This was the example we had in the slides.
I'm going to give you a gown and step out of the room. I need you to remove your shirt and binder and cover yourself up.
So this is the correct answer. And so by giving the rationale that we do need to remove the binder to be able to do the chest assessment, does allow the nurse to effectively auscultate, but also maintains that relationship in terms of the patient understanding why. So now we're going to do the assessment. and we're doing a respiratory assessment. And so we do need to think about the chest wall and breast tissue when we're doing respiratory assisted. So this is relating to clarifying what the patient's naming of their own anatomy is, using standard anatomical terms, or avoiding anatomical terms completely. Anyone have a thought? Why don't we do number 2? No one's jumping in.
Before I move on to examine you, I just need you to know that I'll have to auscultate under your breasts. So I'll need you to lift them out of the way for me.
And I love his face. So the failure to validate his preferred terms. So one of the things with providing culturally humble care to trans individuals is that we really need to use the terms they use. So one of the things that I do in practice is I talk about, I do need to do an assessment. What do you want me to call whatever part I'm assessing? So he may have said, you can call it my breasts, but he may have also said, please use my chest wall. So by you not making that assumption is important. And Barb, I know you said that he's a great actor. He is an actor, but he is a trans man with lived experience. And so this is one of the reasons why we wanted community members involved to get that authentic experience. So what is the correct choice?
Actually, I think Barb wanted to see 1.
Oh, Barb wants to see 1. Okay.
Yeah.
Before I move on to examine you, I'd like to ask you your words for your anatomy. I'm happy to use the medical terms or any other words that you use.
Just say chest.
So it's very easy. You just ask their preferred terminology. So it respects them, it respects their gender identity, and it empowers them in their assessment. Laura has a question, sorry.
Yeah, I guess I'm just wondering what the problem would be with using chest at the beginning, because to me that sounds like a neutral term.
Yeah,
So-
for sure it is a neutral term, but I think in order to demonstrate this through this means we just picked that out for this case. But because you do have to actually lift the breast, and normally a person would say, I'm just going to move your breast, it does give an opportunity to say, what do you call your anatomy? And Erin, look, sorry, I cut you off there.
Yeah, and I agree 100%. My natural instinct would be to use the chest wall. However, I was burned by a patient who didn't have a problem with his breasts and was really offended that I was minimizing his breast. He identified male pronouns, but very non-binary, and it kind of was really disruptful when I tried to examine him. And so it's just, again, that thinking of from a cultural humility approach, you're recognizing your own biases and limitations. And so you're not making any assumptions. But yeah, chest obviously is very neutral. And that it's not that it was a wrong answer, it's just not the best answer. And that's what's with these answers, is there's a really good answer, there's an okay answer, and then there's a wrong answer.
And it certainly then provides a segue. We didn't show any videos of any other sexual health type physical assessments, but certainly for somebody who's nervous about having their pap smear done or anything like that, then it provides an opportunity to say, now, here's what I need to do, but before I describe what I'm going to do, like, I need to know what you call your own personal anatomy so that you're comfortable, or what would you like me to call it here today so that you're comfortable, and make that transition.
So here we're listening to the chest.
Right.
Without a binder.
Okay, Connor. I've had a good listen, and I hear some decreased air entry, and I can hear some noises in your chest that suggest you might have a pneumonia. I'd like to send you for a chest x-ray.
So now we're talking about continuing care and referral of care and involving another healthcare practitioner. So one of the things that we know with x-rays is that they always want to ask for the pregnancy status prior to someone having an x-ray. So how are you as the nurse going to address this before the x-ray? So it's not necessary because the patient's a trans male. Inquire if the patient could be pregnant, or normalize that you need to ask for pregnancy status. So this is a challenge. One of the things I always talk to my patients about as a sidebar is that, you know, I do have to think of the parts you have, even if you don't want them. And so this is why we're including a pregnancy status question in here. Any thoughts? Oh, lots of different. So there was a 3, there was a 1. Oh, a 1. Let's go 1.
Since you're trans,
So we've made the assumption that he can't be pregnant because he's trans, which is not true. And obviously he was a little flustered that we made that assumption.
Number 3.
Yeah.
So Connor, having an x-ray is risky for anyone who's pregnant. I don't know if you've had bottom surgery or have had a hysterectomy, which is when your uterus is removed. But if not, is there any chance you could be pregnant?
I haven't had bottom surgery, but I'm not sleeping with anyone who could get pregnant.
So you've normalized about pregnancy status. I ask everyone, it's a risk for everyone who hasn't had bottom surgery. You're respecting it, you're giving him the offer. And as you can see, he was very respectful and responsive to your question because of the way that you asked the question. Oh, can we go back? Because Barb really wants to see what 2 says.
Oh, you can't go back.
Sorry, Barb, once you pick the right one, you go forward.
Yeah, that's right. I know that's what when I've done other videos, that's what I've seen. So I'm not sure if there's any option to be able to go back, like just to in terms of that learning opportunity to see what the wrong answers were. But I see there's not.
So Barb, the reason why we've done that was intentional. It helps to facilitate learning. So having the student get the right answers and then go back and look at the wrong answer. So the more they play the game, the more that muscle memory is in there, your repetitive exposure to the situation. So it was a conscious decision by the team to, when we created the template, not to have a previous button.
Okay, great. Thanks for explaining.
I'm sending a patient down to you for chest x-ray. Can I talk to the x-ray tech who will be taking care of them?
Hi, Jen. This is Anjali. I will be taking your patient. Can you tell me about them?
So what specific gender information do you actually need to provide in the handover? And remember, one of the things that we want to be very mindful of is that we're providing appropriate information. It's not a gossipy thing. So do we want to include gender specific information? Do we not need to? Or does the whole talk actually just need to be about the individual's gender? How would you hand over a report? Let's look at 1.
Or do we want to look at any? Oh, well.
Patient is Kate Sitchuk, goes by Connor, a 37-year-old transgender man who uses the pronouns he and him. He has decreased air entry in his right lower lobe and crackles and wheezes throughout, so he needs an AP and lateral. His experience at the clinic this morning has been difficult for him as he was misgendered and misnamed both at reception and then by me in the exam room. So if you could just be aware that his name is Connor and his pronouns are he and him, and don't go by what you see in the chart. I've confirmed already that there's no chance he could be pregnant.
Great. Thanks for letting me know. Can you send him down?
Yep.
So very specific gender information, confirmed the pregnancy status so that there will be no more issues for this patient, hopefully when they go downstairs to have their chest x-ray. And I know a couple people have said that they want to see the wrong answers, so feel free after to play as much as you want with the wrong answers of all the games. But yeah.
Certainly the focus on gender one, I know I've heard a bit of feedback that people maybe felt like, well, it sounds like it's okay. Some of the answers are okay, but then when you click it, the response is really not what you intended by focus on gender. So if you were to like maybe expecting what we just heard as sort of the focus, like focus what you're going to say about their gender. Whereas the focus on gender one is really, it's actually a little difficult for the person who was our community member when they were writing it to be quite so, well, this is what a really horrible report would sound like, because the nurse in this says like, oh my gosh, we've had such, it's a real med room chat. Like we've had such a morning with this patient, like first at reception, and then they got huffy with me, and like I just can't, you know, anyway, he or she says, and just misgenders like purposefully throughout. So just know too that if you're doing this with students, that you want to be aware that some of the language, some of our actors had a difficult time, and a couple asked for minor script changes for things, so that because if anyone is gender non-conforming or sexual orientation questioning, it could be really challenging for them as well. And so just to have that preamble.
Yeah, and Laura, your point there in terms of triggering students, I mean, it is always important whenever we're talking about these things to create a safe space in the classroom. And so we, you know, having a place where students, you know, can view these on their own or debrief is really important. The aim is to do good, not harm, right? So you've successfully completed the simulation game, and then you would be able to continue, and it takes you back to, obviously, well, it first tells you who was involved, and then it does take you back to the options of doing another game or going to another section. So that, again, that's just one of our games. We have 4 games up here right now. We have other games that we have filmed. We filmed 3 this week. We filmed 1 a couple weeks ago. So we are adding more content, but I'm going to just being respectful of time. It is we've got about 6 or 7 minutes left. If there's questions either in the chat box that we didn't see, or if you want to open the cultural safety continuum slide. Where is that?
So that's federal provincial health, or sorry, public health. The stigma report 2019 stigma report through the Public Health Agency of Canada. And then their follow-up one is COVID related, but links to the stigma report. You're welcome.
I don't know, Marion or Jane, if do we want to show a French game really just so that because it is bilingual?
Sure,
I think for the trailer.
There's 2 here. One is English, one is French. So I'll just quickly show you the French.
Bonjour, je m'appelle Julie et je serai ton infirmière aujourd'hui. C'est bien Olivia?
Non, je m'appelle Olivier.
I apologize, my French is not up to par, but basically this is the exact same game, the exact same script. It has just been translated.
And ideally we would have a French website as well, but we need to find some Francophone collaborators to help with that. But at least we have the games available in French.
And that's coming soon. We'll be working on that in 2021, so we'll have that available to everyone. So as we said, like, excuse me, all of the games have been professionally translated and have been filmed with French actors, authentic actors, and we'll be bringing that. Those are available on the English site under the game link in French. I'm just wondering if anyone would be interested in just seeing a quick trailer of the SOGI website, and it can kind of quickly go through all of the games that we have that are in English, a little bit in French, to give you a little bit of an overview.
Hello, Kate. I'm Jen, the nurse practitioner.
My name is Connor. I've gone through this with the receptionist. Did she not tell you? Because my birth name was Kate, but I go by Connor.
My pronouns are she and her. What are yours?
He and him.
And do you identify as transgender, non-binary, or something else?
No, I'm a trans man.
So I'm just going to go ahead and ask you some questions that we ask everybody at these appointments.
Yeah, okay.
Have you been sexually active with men, women, or both?
I've had a girlfriend who I've been sexually active with for the past 3 years, but I had a boyfriend in high school.
I have to admit my knowledge is somewhat limited, but I do know there are community-based resources that might be helpful for an in-person connection, and there's also some trusted websites.
I really appreciate that. I don't really feel comfortable going to CC right now, but I'm more comfortable online.
So it sounds like John was your primary support. Was there anyone else that you and John were close to?
I'm so isolated. He was my everything. As for friends, since we did a lot of couple things, I haven't really heard from our friends since he died.
Looks great, Jane.
Great.
And one question I know we'd gotten from another group, and one thing in that I noticed was that another good learning point with students is for them to be critical of our website too, that there are a few places where we've said things maybe not in the best way, even in the right answer. And so reinforcing a binary, for example, like asking, do you sleep with men, women, or both? Or do you sleep with men, women, people of all genders, that kind of thing. So certainly encourage students as they're watching to continue to be critical, and the language is always changing, and to bring that confidence that they bring from their own experiences to the conversations and discussions they have using the website.
And I think that really lends well to a really rich debrief. So these games, we have options for virtual debriefing, and we really recommend that you provide that if you're displaying this to students or even to practicing nurses, if you get into a group and have a facilitated debrief where everybody can explore their thoughts through self-reflection to really enhance the learning.
So Laura asked in the chat to clarify, is it one game that takes about 3 hours, or a combination of games that take a combination of more than one game? And it's the combination. So we saw one game to its completion, and that was one of the longer games. So there's a handful of longer games. There's several short mini games that are only 1 or 2 choices. And there's the preparatory sort of PowerPoint slideshows. And then just reading through a few resource documents that are sort of like about critical personal reflection and yeah.
I would like to thank Dr. Erin Ziegler from Ryerson University and Benjamin Carroll from Queen's University and the Ottawa Public Health Unit for this great presentation. I hope this provides more information about the new SOGI website, Sexual Orientation and Gender Identity. If you have any questions or concerns, please don't hesitate to contact Erin or Benjamin or leave a message on the CanSim website. Thank you.